Hi everyone, welcome back to another Rafael Medina's of a specialty VMR. Today we have a neurology edition and we have one of our recurring discussants and star member of neurology of a specialty VMR, Dr. Shi, with us again. And I had the pleasure of discussing with her this time. So, Dr. Shi, maybe you can introduce yourself for the people of the audience that may not know you and tell us a little bit about what you're up to during this time of the year.
Hi everyone, I'm Helen Shi. I'm one of the neuro hospitalists at Emory University Hospital in Atlanta, Georgia. This time of year, I am on service a lot and just came off service yesterday. Lots of many interesting patients and looking forward to relaxing this week. I hope everybody is well. I'm excited about this case.
Awesome. I think my Wi-Fi is a little not working well right now, so I'm gonna switch. But so in the meantime, maybe I can pass the mic to Sarah and Glenn to introduce themselves.
Hi, I'm Sarah. I am a fourth year medical student at Emory. I'm really excited to be scribing today.
Hello everyone, my name is Glenn. I'm a medical student in Botswana, doing my final year. I'll be doing teaching points today. Looking forward to the learning from everyone.
Okay, I'm back. Thank you everyone for the introductions. I'm Vale, I'm co-discussing today. I'm calling from Lima, Peru, and I'm applying to the match this cycle for neurology. And before we get started, I'm gonna pass the mic to our case presenter, Fahid. Thank you so much for jumping on the presenter seat very last minute. Could you please introduce yourself for the audience?
Hello everyone, I'm Fahad and I'm very excited to present this case here today. This is my first time presenting in a neurology special VMR and I'm looking forward to it.
Thank you. So without further ado, could you please tell us your first aliquot?
Yes, so usually when I present the first report, I just give the chief complaint and let the discussants do the discussion. But in this case, as there is a lot of chief complaints, I'm just trying to streamline things into a single chief complaint. So my aliquot one is that a 63-year-old male who presented with 9 months of abnormal sleep behavior, mainly consisting of dream enactment. So when you hear such a complaint, how do you approach such a complaint and what would the localization be in terms of step like?
Yeah, thank you for this, Fahad. For sure, sleep issues or sleep neurology in general is a topic that's very intimidating for me. I think it's quite complex. And it's been very helpful for you to specify what type of sleep behavior disorder this patient is having, dream enactment. I think dream enactment, if I remember correctly, is a type of like REM sleep disorder or like um if immediately I think about like patients that have Parkinsonism, Parkinson's disease, usually like REM sleep disorder is one of the first things that present before the motor symptoms. But then where do I localize REM sleep disorders? With the sleep, I think the structure that jumps instantly is the hypothalamus, but I know that sleep is a very like um, complex input and output and feedback type of circuit. So I also be very interested to maybe see signs that could localize to the posterior fossa, to the brainstem. Those are kind of the structures that are coming to mind when you mention dream enactment. But yeah, we'd love to learn from you, Dr. Shi. How do you approach this unique chief concern?
This is a very interesting chief concern for dream enactment. And um, so my approach to this would be I have many questions to ask the patient and family about dream enactment. I want to know at what stage of sleep, I mean, roughly from their observation, like when do they start enacting dreams? Is it at transitions of sleep as they're falling asleep or as they're waking up? Or is it while it looks like they're like very asleep, which by their report, if it looks like they've been asleep for a while, they're very asleep, maybe that is in the REM period. When I hear about sleep, like movements in sleep or like behavioral disturbance at transitions of sleep, it does make me think about, are we really talking about a sleep disorder, or could it be seizure, as seizures commonly occur at transitions of sleep as people are falling asleep or as they're waking up? And so that's on my differential, is maybe this is not really dream enactment, like maybe the patient is not really well, anyways, but yeah, maybe it's not really a dream thing, but maybe it is seizure, like, temporal lobe seizure or frontal lobe seizure or something that is causing them to have movements that somebody might interpret as them enacting dreams, or the patient might report that they were dreaming, but maybe that was like temporal lobe aura. So I'm thinking, is it really a sleep disorder issue, or could it be seizure? I also want to know if there are any other associated symptoms, like do they notice any hallucinations, like hypnagogic hallucinations, hypnopompic hallucinations, and one of those is hallucinations when people are falling asleep, and the other is hallucinations people have when they're waking up from sleep. And I also want to know, I see somebody, Sayers, putting in Parkinsonism, which is what Valeria was also talking about, is that REM disorders with sleep dream enactment is a very common, like kind of like prodrome in patients with Parkinson's disease, just like patients with Parkinson's disease having like constipation and anosmia prior to having motor symptoms of Parkinsonism. So I'd be curious, with a neuro review of systems and also a general review of systems, what else is going on with the patient?
Amazing. We are looking forward to your next aliquot for head.
Yeah. So this is a case of a 63-year-old male with no significant comorbidities, presented with 9-month history of progressive fatigue and unsteadiness of gait, which is characterized by swaying predominantly to the right side, and it ultimately resulted in difficulty while walking. Over the same duration, patient also developed abnormal neck posturing, characterized by sustained forward flexion, which progressively worsened. He also reports excessive daytime sleepiness with an altered sleep-wake cycle. For the past 9 months, the patient exhibited abnormal sleep behavior, which is characterized by acting out dreams in his sleep, which include vocalization as well as movement. So whichever dream he's seeing, he just vocalizes it and tries to move his body according to it. Now, additionally, the patient also experienced intermittent hallucinations and delusions, which were episodic in nature over this period. He also gives history of episodes of urinary incontinence, which is predominantly nocturnal. Now, over the last 6 months, he also reports that he has an unintentional weight loss of approximately 10 kilograms. His past history, family history, is within normal limit. Personal history, as I said, there is altered sleep and episodic urinary incontinence. Addictions, he has mild smoking history. Otherwise, it is normal. So I know this is quite a big aliquot. So in total, the primary complaints were unsteadiness of gait towards the right side since the past 9 months, abnormal neck posturing since the past 9 months, excessive daytime sleepiness and abnormal sleep behavior, behavioral disorders like hallucination and delusion, intermittent urinary incontinence, and significant weight loss of 10 kilograms since the past 6 months. And I'll stop here.
Well, Fahad, your presentational skills are super impressive, and I really appreciate you outlining this so clearly. Yeah, so I think several things come to mind, and for me, it's quite hard not to be biased and to think about one specific diagnosis when you mentioned like swaying to one side, like asymmetric swaying. The forward flexion makes me maybe think like there's maybe some rigidity there, and then we have the possibility of autonomic symptoms here with the urinary incontinence, as well as some signs of like this chronic disease happening. I think I'm just gonna say like my system one thinking when hearing this presentation was like a Parkinson's plus syndrome, like multiple systems atrophy. I've seen a patient once that had like a PISA sign, which is like, I'm not really sure what on what time of the disease progression it happens, but that basically present with like posturing to one side. That the name comes from like the Pisa Tower. So the patient sway permanently to one side. And the muscle systems atrophy syndrome is a Parkinson's plus because besides the Parkinsonism, the main thing that presents with is that autonomic dysfunction, which I believe would precede the motor symptoms or like will be more predominant than the motor symptoms. So that's like my system one thinking. But if I take a step back and be like, okay, what else could it be? As Dr. Shi mentioned, I think I'm really looking for an exam to do like a Parkinsonism focus exam to look if there's like some rigidity, the gait of the patient, if there's like some petit pas, reduce like reduce step and turning, if there's some problems with like repetition of movements to see if this could fit. And then and I'm also really interesting. I think it's really interesting to characterize the urinary incontinence. So, like, if this is an autonomic thing that's going on, or for some reason there's like a multifocal thing happening that is also affecting the spinal cord. I wouldn't want to miss that. But I think the time course would be quite you know, I guess if there was something on the spinal cord happening with urinary incontinence and gait abnormalities, probably I would expect some like more like sensory problems or like a more pronounced on the lower extremities if that was the case. But I think that's where I would be focused on my exam. What are your thoughts, Dr. Shi?
I absolutely agree, Vale, that Parkinsonism and one of the Parkinson's plus syndromes or Lewy body disorder is highest on my differential right now, just from the history that I agree, it does sound like there's rigidity with the neck forward flexion and the leaning towards one side. Also that there's gait instability. We're not hearing about any tremor or hyperkinetic movement. But with the hallucinations and delusions, which oftentimes occur pretty prominently in Lewy body disorders, and also Lewy body disorders often feature alterations in levels of consciousness, just like in a day-to-day basis. Sometimes, if you hear that a patient has, is more drowsy, lethargic, taking more naps, that there's just more alterations in their level of alertness with Parkinsonism. Definitely think about Lewy body disorders, and I'd be curious to know if this patient, if the family or the patient have noticed any cognitive symptoms. Also interesting that there's unintentional weight loss. I'm not sure how that plays into this person's presentation, if the unintentional weight loss is related to dysphagia that could be part of a neurodegenerative disorder, or if the unintentional weight loss is related to loss of appetite, or maybe they have anosmia, so they don't smell things, like the food just doesn't taste the same. Or if this is something a little more concerning, where they're losing weight, is there malignancy? Could this be a perineoplastic presentation? This is he's coming in for dream enactment, which I really doesn't make me super concerned about a perineoplastic condition. But then we're hearing about hallucinations and movement disorders that. But everything sounds like it's been going on for 9 months. So it's just in the back of my mind. Like, why is this person losing weight? How does that play into this person's presentation?
Yeah, amazing discussion so far. So I'm just gonna carry on with aliquot 3. Now, the patient, they're coming to the examination. The patient is conscious. He is moderately built and nourished, and he doesn't look ill. A general physical examination is unremarkable. Vital parameters are stable with a pulse rate of 95, blood pressure of 130/90, respiratory rate of 18, and he was afebrile at the time of exam. Now, the cardiovascular system, pulmo, abdomen, all are within normal limits. So I'm going to straightly jump into the neuro exam. So coming to the higher mental functions, the patient is conscious and oriented to time, place, and person. He is a right-handed individual. Good appearance and behavior. Speech is normal with good fluency. Comprehension and repetition is intact. His memory is preserved with immediate, short-term, and long-term memory tested, all three being preserved. Coming to cranial nerve exam, cranial nerve 1 and 2 are normal. In cranial nerve, in exam of cranial nerve 3, 4, 6, there is no ptosis. Extraocular movements are full and unrestricted, but he is found to have broken pursuits and hypometric saccades, and all other cranial nerves are within normal limits. And I'll stop there.
What a beautiful exam, Fahad. Like, don't like a true neurologist. I mean, I really, really love how you outline everything. I think what's jumping to me is, the broken pursuit and the hypometric saccades. I think those, I mean, it's very hard to like name a saccadic disorder, I would say, at least from my experience, but when you name it, I think it has a great localization power to like where could we localize this lesion. And I think when it comes to like problems with saccades, I'm thinking, is there something on the cerebellum that could be affected as well? I'm not sure. Oh, wait, no, let me take that back. Because in the context of a patient that we are suspecting of, uh, Parkinsonism, saccades are still a movement, right? So hypometric saccades would, I think, fit on that uh, like a slowing of movement that we would expect on a Parkinsonian patient. So I think that's another clue that this patient could have Parkinsonism. I almost got like taken away by my kind of instinct to try to localize where could this be, but I think maybe the motor exam would be more enlightening on that sense. What are your thoughts, Dr. Shi? I'm curious how you interpret this cranial nerve exam.
Yes, yeah, I agree exactly with what you're saying, that hypometric saccades do make me think about a slowed movement issue. And that would really, the Parkinsonism is what I'm thinking about. Um, and it just for everybody's understanding, hypometric saccades means that, or at least the way that I would test it would be, to have like two objects and be like, look at my thumb, look at my finger, and can you look at my thumb, look at my finger. And so you're just asking them to saccade back and forth. So different than testing for extraocular movements where you're checking their pursuit of your finger as you are moving in different directions of gaze. And so saccades can be helpful in a variety of ways, but seeing if they're hypometric, it does make me think about a hypokinetic movement disorder. And then if people overshoot with their saccades, I do think about other localizations, like you're saying about cerebellum or brainstem. For broken pursuit, in my this is like not super insightful, but the way that I think about broken pursuit, or somebody might call it saccadic pursuit or non-smooth pursuit, which is like when you're having them focus on your finger and checking their extraocular movements and noticing that their movements are not smooth but rather saccadic, so jumpy. They're like trying to follow your finger, but they're like having to make saccades to follow your finger and not pursue very smoothly. This, I realize, is not very helpful, but the way that I think of it is that this person is having a brain or brainstem problem, like, uh, which I think like nobody is surprised that like that's what we're thinking about for the localization. I think of so to have smooth pursuit, you need to have intact, like many areas of the central nervous system have to be intact, including occipital lobe, temporal lobe, frontal lobe, and brainstem functions, but especially the supratentorial functions. And so I think of it as being, we certainly see people have non-smooth pursuit or, saccadic pursuits, broken pursuit in patients who have neurodegenerative disorders and people who have had a lesion to any of those structures that I just mentioned, like they've had a stroke in the past or they have MS or, there's some structural lesion that's preventing them from having smooth pursuit. The other is I find it most useful when somebody presents and you're not really sure if they're having a central nervous system disorder or not. So, in a separate patient, like somebody who is someone who presents with like seizure versus syncope, like first episode of life, and they passed out and they shook for a couple, for 30 seconds, and then it wasn't clear if, maybe they were confused just for like a minute or two. And so it's like not really clear, like, was that syncope? Was it a seizure? And on your very thorough neuro exam, if you notice that they have non-smooth pursuit, then I would be like, oh, I think there's a brain problem going on. Like, I don't think that was just syncope. I think in a patient like this, it is still very useful to observe this and do a very thorough exam. But I don't think it helps my localization a whole lot other than validating that, there is something going on with the central nervous system that, based on the story, sounds neurodegenerative and it sounds like he's Parkinsonian with the hypomatrix saccades. I'm interested to hear more of his exam.
Yeah, before you give us a little bit more information, Payet, I just wanted to highlight Noah. I saw that mentioned in the chat the anti-IG long 5 syndrome. And I just want to mention it because I remember when I did my rotation with Dr. Shi at Emory, we saw, I think, a patient that you had referred to us, Dr. Shi, but you were not there, that had, like, we suspected she might have anti-IG long 5. And just to like mention what that it could entail, I think my reading from that case was that it usually presents in younger people, maybe like 40s. And I'm not sure if that age would fit with the patient that we're seeing today. But one of the main teaching points of that case is the possibility that autoimmune encephality could have a chronic course and not so much, the typical acute anti-NMDA picture that we associate autoimmune encephalitis with, but more like a chronic and even overlapping with like a neurodegenerative type of picture in which we see, cerebral degeneration. And it could present with a lot of things that we are kind of getting a sense of right now, like a Parkinson plus type of picture, but more so associated with like the brainstem type of lesions, which would cause like the midbrain type of lesions, which would cause more like a PSP or PSP, which is, another type of Parkinson plus, which cause vertical gaze palsy and could also present with like sleep issues. But I'm not so sure with so like prominent REM issues. And I'm not sure if that dysautonomia would fit, but just like to mention it like as a teaching point and because it reminded me of those good old days we had back in May. But yeah, take it away if I had.
Yeah, so coming to next aliquot. So I'm going to give the motor system examination. So in examination, there is bilateral wasting of both upper limbs and lower limb muscles with the presence of diffuse fasciculations. The tone is normal. Power is 4/5 on both upper limbs and lower limbs bilaterally. Coming to deep tendon reflexes, the biceps and triceps reflexes are normal, the 2+ on both limbs. Supinator, knee jerk, and ankle jerk are absent bilaterally. The plantar response is flexor bilaterally, and extrapyramidal system exam revealed that the patient has a presence of axial dystonia of the neck and trunk, more towards forward flexion of the neck, and there is presence of myoclonic jerks, and there is presence of mild tremors. Cerebellar exam is normal. His gait we were only able to assess the gait for a short period of time, and he was swaying to the right. Sensory system is completely within normal limits, and there is no signs of any meningeal irritation. And I'll stop here.
Wow, this is a very interesting exam, Fahad. Thank you so much. I see things that I was not really expecting, like, for example, the diffuse fasciculations are one of the things that are very interesting to me. And also the diminished reflexes on the lower extremities. I think when it comes to like just fasciculations, the first thing, of course, that comes to mind is could this be ALS? Which I think it's an interesting thought that I'm very biased because I recently read about the association between ALS and Parkinson plus syndromes in particular, like, well, not Parkinson plus, but frontotemporal dementia and um, it could also present with Parkinsonism, actually. But I'm not sure if how much am I putting on these fasciculations being like, could there also be like two completely separate problems going on right now? And then we see signs of like lower motor neuron disease potentially on the legs, and what else we see? We see myoclonic jerks and mild tremor, which I think could be a point towards our hypothesis that this is Parkinsonism, especially the tremor. Would want to assess if it's like tremor at rest or with action. That's why into the right is also a point towards our Parkinsonism. So yeah, I'm a little puzzled by this. So like the coexistence of lower motor neuron signs with Parkinsonism would want me to seek if this is motor neuron disease happening with Parkinsonism syndrome overlapping. So yeah, that's sort of my thoughts. Would love to hear you, Dr. Shi.
I agree with you, Valeria. I am more puzzled after hearing this exam. I agree, it is not what I was expecting. I was expecting to hear about a lot of Parkinsonism, and we'd be like, um, just carrying on with that as the main differential. But I agree, there are findings that I think are most atypical for what I was expecting is the lower motor neuron signs, like you're saying, that there are fasciculations, which fasciculations as a lower motor neuron sign, it doesn't equal ALS, but it is ALS is definitely on the differential. People can have fasciculations, from any lower motor neuron process. They have a myopathy, they have a peripheral polyneuropathy, they uh, like muscle disease, nerve disease, lower motor neuron processes. Um, and so, but seeing fasciculations in combination with diffuse weakness and hyporeflexia, I mean, like very much we're thinking that there's a lower motor neuron process in addition to what sounds like, central nervous system issues, because there's like the dream enactment that he came in with and the hallucinations, delusions. Um, the other thing that is unusual is the myoclonus. I'm also curious, like in addition to characterizing the tremor, tremor more, I'm also interested in hearing more about the myoclonus. If you're able to tell us, like, was it positive myoclonus? Was it negative myoclonus? A positive myoclonus occurs when, or so like, what is myoclonus? Myoclonus is an intermittent irregular jerk. Positive myoclonus is an intermittent irregular jerk that occurs when a muscle group is at rest. So, for example, somebody who's just like sitting there and you're talking with them, and then all of a sudden their like shoulder has a myoclonic jerk, or their arm, jerks up, or their leg jerks up. They're just a little twitchy. And negative myoclonus is an intermittent irregular jerk that is a loss of muscle tone when a muscle group is activated. And so when we check for asterixis, like somebody who has hepatic encephalopathy, you're just, doing your exam and you have them hold their arm up. And so to maximally activate the upper extremities, it is most useful to hold the arm up and dorsiflex, extend the wrist back and extend the fingers. So you're maximally activating those muscle groups. And then you can notice if they have loss of muscle tone. That kind of subtle is just like the fingers having a loss of tone and they recover rapidly. But more obvious would be if they have like an entire like loss of muscle tone of their upper extremity. So I'm curious to know if it is positive or negative myoclonus. Um, Negative myoclonus is more oftentimes associated with toxic metabolic issues, and also is the myoclonus diffuse, involving like all the extremities and maybe even the neck, facial muscles, or is it more localized, like more focal, which could help us also localize to a more focal lesion. Um, myoclonus, when I think about somebody who has some Parkinsonism, that maybe is rapidly progressive and also having myoclonic jerks and something like I don't know. I feel like it's really not exactly the story, but um, CJD can have a cerebellar predominance and also have like rapidly progressive Parkinsonian features and can feature myoclonus, but usually those are patients that have that like rapidly progressive dementia. So, just in the back of my mind, I'm like, why is this person having myoclonus when I thought that they would just be Parkinsonian and having REM sleep behavior disorder? I'm thinking, do we need to expand to other processes that affect multiple parts of the nervous system? And so I'm now also thinking about that like paraneoplastic conditions are back on my differential or like higher on my differential. In the back of my mind, I'm thinking a little bit about CJD, wanting to know more about their recent mental status. And also thinking like, is there a lower motor neuron process going on? I think an EMG would be really helpful in this patient who's having fasciculation and weakness. And then also thinking about more systemic processes. Although I think things like Wilson's disease or like heavy metal poisoning or like exposures, I'd want to know a lot about are they taking supplements or have unusual hobbies with exposures.
Yeah, I really appreciate you. I feel like your discussion kind of highlighted a lot of the biases that I had because I think as a junior learner, my instinct is to like clump everything together and be like, this is one thing that could explain the final diagnosis. But I think it's quite smart to be like, could there be many things going on? And I think for sure ruling out this is not like Parkinsonism secondary to some medication that the patient has been taking and is like the main thing is not the Parkinsonism but rather something else, and to ask the possibility of more not necessarily like neurological things going on but could present like a neurological syndrome, so like ruling out all those toxic metabolic and medications. I think is really 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 wise. So yeah, we're excited to hear more of ahead.
Yeah, great discussion, guys. And to answer you, Dr. Helen Shi, so the myoclonus was, I think I saw this patient about a long time ago, so I don't actually remember which all muscle groups were involved in it. But as far as I believe, it is positive myoclonus, and at rest, he exhibits sudden involuntary movement of the neck and shoulders. If I'm right, I'm not sure, but I think it's neck and shoulders. So I'll just give you the initial labs as well. So a complete blood count was done, which was within normal limit with a hemoglobin of 13.1, WBC count of 5,900, platelet of 250K, and the ESR was elevated at 40. Further, renal function tests were within normal limits with a serum creatinine of 0.6, sodium of 143, and potassium of 3.9. His glycemic control was assessed and HbA1c was 5.3. Further, his liver function test was also done, in which the liver enzymes were within normal limit, except for with an albumin of 4. The thyroid status was assessed. His thyroid status was assessed with a TSH of 2.65, which was within normal limits. Now I'm going to give you the MRI findings. So an MRI brain was done, which was normal with no significant brain atrophy in any of the lobes. MRI of the cervical spine was done, which showed a mild disc bulge at C4 to C5 and C5 to C6 levels. And further, an EEG was also done, which revealed generalized dysrhythmia. And we were not able to do a sleep study, so it was not obtained. And I'll stop.
Okay, I was not expecting that. I'm not really sure how to interpret dysrhythmia. EEG is not really, I mean, I need to get better at interpreting those for sure. But I would be, um, you know, be like, okay, this is not typical, I would say, for what we were thinking of Parkinsonism, right? Like, is this arrhythmia? Is this patient having seizures, and is it accounting for their motor symptoms? I'm not sure. That could explain everything, but it's for sure interesting that it's happening. Um, I guess I could make more progress with the labs, just to say like things that we are maybe less concerned now, like a metabolic syndrome going on, like for sure this patient may not have like a periodic paralysis secondary to like hypokalemia or something like that. Um, and then we have a normal MRI and a normal MRI cervical spine. Or well, not a normal, but mild disc bulge, which I think could not account for the lower motor neuron signs that we're seeing now. What does a normal MRI make me like in progressing wise? Um, things that would at this point I think present with like an abnormal MRI, maybe CJD. Um, I think it's a rapidly neurodegenerative condition, so maybe that's a little lower on my differential just based like on taking on the value of a normal study. Then Parkinson plus syndromes tend to have signs on the sagittal and axial cuts, like the um, I'm blanking on it, but like so we would see like in Lewy body dementia, maybe some frontotemporal atrophy. In MSA, we would see like the bird sign on the midbrain. I don't remember what it's called. And then
Hummingbird sign.
hummingbird sign. And then corticobasal atrophy, we would see degeneration of the cerebellum. So yeah, maybe less likely, but I'm not really sure how to make progress. And I'm for sure very, very puzzled about that dysrhythmia. And what does that even mean? So yeah, I'm seeking your assistance, Dr. Shi. Please help me on this one.
I agree. I am underwhelmed by all of the results so far, except for the dysrhythmia. And I agree. Like, what does that mean? Does it mean like generalized slowing? Is it just slowing? Or does it mean that there is epileptiform discharges? It seems like maybe but he means generalized slowing. Can you clarify?
Excuse me, I didn't hear it actually. What was your question again?
My question is, could you clarify the EEG finding of generalized dysrhythmia? Does that just mean generalized slowing, or does it mean something more concerning, like epileptiform discharges?
Yeah, I think it just means that there is generalized slowing and the rhythm is less organized as such.
Okay.
Okay.
Yeah, so like not honestly not super helpful. Or I mean, like you're helpful, but the study did not provide a lot of information because lots of people have generalized slowing, and we're already thinking that something is going on with this with the brain, and um, fortunately, we're not seeing focality or triphasic waves if there's no reason for them to have triphasic waves. Triphasic waves can be seen in CJD, but also in toxic metabolic issues, toxic metabolic encephalopathy. And I appreciate that a brain and spine MRI were both performed. Hopefully, they were done with and without contrast, just because this patient's history is, or the differential for this patient is still relatively broad, and would want to know if there's any abnormal contrast enhancement. But from what's told, at least we are able to see that there's no yeah, no findings that are concerning for CJD, which we would see, restricted diffusion along the cortex and the basal ganglia, thalamus, like that hockey puck sign and that region, or sorry, hockey stick sign in that region. And also that there's no findings of like temporal lobe, limbic lobe enhancement or flare changes, or cerebellar brainstem degeneration, or like abnormal enhancement in those areas. And also that the MRI cervical spine shows that there is no reason for this patient to have weakness in all four extremities. And even though the findings weren't suggestive of an upper motor neuron, of like a cervical myelopathy, since there was no hyperreflexia, and also since we're seeing fasciculations, but we now see that there appears to be no reason for this patient to be weak from the brain and cervical spine. We need more studies.
Yeah, just like a brief question, Dr. Shi, what do you make of the elevated ESR? Because I just noticed that it's like highlighted on red, and I'm wondering like any of the hypotheses that we have would leave such a like inflammatory mark on the body.
Yeah, I am generally quite unimpressed by ESR, and I actually I really do operate on like if the ESR is less than the patient's age, then I don't think it's elevated. And so I wouldn't have highlighted it as red. I mean, I know it'll flag as abnormal in the labs, but I would consider this to be normal for the patient's age.
Thank you for the teaching, Pearl. Fahed, take it away.
Yeah, so the next record carries out a series of investigations we have done. First, a nerve conduction study was conducted, and it demonstrated that the patient had bilateral lower limb early sensory motor mixed neuropathy. So basically, both sensory and motor nerves were affected. Now, an electromyogram was also done, and it showed that there is diffuse fasciculations noted in the cervical, thoracic, and lumbosacral muscles, and there is reduced recruitment from bilateral tibialis anterior muscles. Further, a CSF study was also done in which there was no red blood cells, white blood count of 2, sugar was 79, and CSF protein was 62, which was mildly elevated. Further, due to concerns of paraneoplastic syndromes, we did some paraneoplastic workup, which was limited, such as CT thorax and abdomen, which was within normal limits. And further, a serum paraneoplastic panel was also done, which also came back negative. And I'll stop here.
Yeah, this is very interesting. So I think the EMG for sure confirmed the coexistence of the Parkinsonism and the motor neuron disease. The fact that there's fasciculations and reduced recruitment, and I'm not really sure. So is this like there's neuropathy with sensory motor? So could it be like, I guess, when we think about motor neuron disease, we think, okay, it's only motor, but there are some variances that may also have like a sensory component to it. Or is this just like a pure mixed neuropathy and motor neuron disease and things, localizing upper on the CNS? Um, then, so what do I make of all these things coexisting? I think the paraneoplastic panel was a great thought. We were talking about long 5 being a possibility here, and I think that's a great thought as well. I believe, but then there are many paraneoplastic and autoimmune encephalitis that I don't remember the name, but maybe on the table as well. And I think when it comes to like long 5, the turnout of like a positive antibody is not necessarily the best. So I'm not really sure if, the negative paraneoplastic panel would sway me away from that. I would be interested to know exactly what type of panel was done, like a live-based cell type of panel, or it's just like an antibody which will not have the best sensitivity. So yeah, I'm not really sure. Could you please help me, Dr. Shigis, interpreting the like the neuroconductive studies with the EMG? Is it like a motor neuron disease and a neuropathy with sensory component, or could this just be explained with motor neuron disease all along?
I agree that it is not clear to me. It seems like there is definitely a sensory motor neuropathy. I'm curious to know if it's axonal or demyelinating. I also would be interested in knowing the severity, if it would be like if it would explain the degree of weakness that the patient has. Um, and his sensory exam was normal on exam, and so I am wondering like how relevant is this sensory motor mixed neuropathy? Also, it's labeled as early, and so is this mm, yeah, so not sure at what point this neuropathy has become symptomatic for him. Also interesting that he's like 4 out of 5 on exam, but we didn't really hear about him having weakness at home, or like, and he was still walking. It's like kind of hard to walk with 4 out of 5 strength. I don't know. Maybe there's like a little bit of I'd want a little bit more clarity about um, strength and sensation by history, if I had the opportunity to talk to the patient. But yeah, I don't know if this EMG, like if the nerve conduction study is demonstrating something that is pathological and part of his disease, or if it's just something that's true and unrelated, maybe relating to the weight loss, could have nutritional deficiency, could be just low in something as a consequence of the actual disease that he's experiencing. Um, and so in real life, when we when we do testing and then we get results, we always have to think about in the context of this patient, how relevant are these results? And then for the EMG, he is having diffuse, I mean, the EMG is confirming diffuse fasciculations in multiple body parts. That really sounds, and reduced recruitment from the TA muscles. It really is suggestive of a motor neuron problem. And um, I would be very curious to know if the EMG nerve conduction study report by, I'm assuming like a neuromuscular specialist, and provide a little bit more of a interpretation. But yeah, I'm surprised that uh, I am surprised by this whole story. What are we dealing with? If I were taking care of this patient, I would want, like Valeria is saying, more comprehensive perineoplastic evaluation, including making sure that certain specific antibodies are tested for. For example, like glycine antibody, which can cause people to have the weakness and myoclonus, rigidity. Also would want uh, well, I guess we didn't hear much about the tone, but like GAD65 spectrum of neurological disorders. Um, and so I'd want to do some more of that evaluation. And also take a thorough family history. I mean, it would be unusual, but sometimes people who are older may present with a genetic condition that, um, if this patient had family members, either at a similar age or younger age, who had similar symptoms, I would be interested in having them speak to a genetic counselor and doing further testing. Certainly, things that we're thinking about, or like there are certain conditions that we are discussing, like motor neuron disease, like ALS, that can be inherited, although this patient has a lot more symptoms that we'd expect in somebody with ALS. But also thinking about like mitochondrial disorders, movement, like genetic heritable movement disorders, of which there are so many. Um, So right now, this is a patient that I am puzzled by.
Yeah, Fahid, just for the interest of time, how many aliquots are left? Is this the last one?
Yeah, this is the last one.
Okay, so do you want us to like um put our coin down or on something or
I have no coins.
um I honestly was just writing down where because I feel like it's so much harder when I'm not sure where the lesion is. So like I'm trying to think. We have signs that there may be like a neuropathy, anterior horn disease or like motor neuron disease. We have signs that there's like a brain issue with Parkinsonism and sleep issues. So it's quite it affects both the CNS and the PNS, right? So I think things that could be these multifocal are toxic metabolic things that I want to rule out, like probably go as far as to like activate the neuropathy schema and rule out. Diabetes has been ruled out, but then like HIV, B12, B1, and then other like mineral deficiencies like copper, then heavy metal toxicities as well. That could be anything. An RPR, just to be safe. And then, as you said, Dr. Shi, like, um, how can we make more progress? Like to just like pull the trigger and send like a genetic testing, or like where do we get tissue to rule out some sort of like deposition disease that could affect everything? Maybe, would you? I guess we have a lot of things that we could still send on blood, but then I'm just wondering like where can we like get a biopsy as well? And I'm not sure if that's, maybe a little too radical on my part. But yeah, I'm not sure that's the bottom line of this. And if I was to put my coin on anything, I would say toxic metabolic going on or a Parkinson's plus or an ALS plus Parkinsonism issue maybe. Um, what are you thinking, Darcy?
Um, I agree, Valeria. It is very difficult to for me to come to a clear diagnosis right now because it seems like so many parts of the nervous system are involved, and I have questions about clarifying, like I was saying, like is the neuropathy, like how serious is this neuropathy? Are they able to tell us about the severity? Is they able to tell us if it's axonal or demyelinating? The elevated protein might be relevant. A 60-year-old person, 63-year-old person without diabetes, generally they do have normal protein, like maybe slightly elevated, but is 62 maybe a little bit more elevated than expected? Is this, um, is there like a demyelinating polyneuropathy that is part of the picture? Of all the testing that is abnormal right now, it seems like the nerve is one possibility, or maybe it's axonal polyneuropathy, which brings about thoughts about like, could that be vasculitic, or is it just something that's nutritional, toxic metabolic, or autoimmune, rheumatologic? And so, of all the places in the nerve, like you were talking about, like getting tissue, and I always, also like to think about getting tissue in a case that we don't have a lot of clarity, but at least have areas of the nervous system that we know are affected. And so getting like a nerve biopsy along with the muscle, sometimes there can be neurogenic changes, inflammatory changes that might be missed on the nerve, but is actually seen in the muscle. So, that's a thought, but I really want to talk to the neuromuscular specialist who did this EMG nerve conduction study to see, their interpretation of that study. Because of all the places, I feel like that is one place that we could biopsy. Also, when I think about people having, uh, like issues that involve the central nervous system, peripheral nervous system, there's like just like lots of things involved. Um, Although I've never seen it involve motor neurons, would be things like mitochondrial disorders, just like additional genetic conditions to think about. Um, and So that's where I am right now. I'd want to ask more questions of the patient and family. I'd want to get more clarity on the nerve conduction EMG. And, if I were taking care of this person in the hospital, I'd probably discuss this case with multiple specialists, like movement disorder specialists and neuromuscular specialists. And then, hopefully have additional studies to send. And if really there's like nothing, like no real leads, I would probably give steroids and IVIG for the possibility it's autoimmune perineoplastic, have them get repeat, look at a PET scan outpatient, looking for malignancy, send them to genetics. There's so much more additional testing that can be done to try to figure it out for this patient. I'm very curious to know what the diagnosis is.
Teachers, Fahad.
Yeah, so the final test. So I'll give a bit on the treatment this patient received first. So initially the patient was treated with levodopa because the initial presentation before we got all the other tests were similar to a degenerative extrapyramidal kind of involvement, and the patient showed somewhat around a partial response. Then further, towards the end, an autoimmune panel was done, and one of the antibodies were positive. Any guesses?
Is it anti-long 5?
Yeah, it is IgG5 positive antibody. So the final diagnosis was IgG5 autoimmune encephalitis, which is also known as anti-IgG5 disease. And to everyone in the chat who got it way earlier, so that's the case.
Amazing, Fahad. Do you have any reflections about taking care of this patient that you would like to share with us?
Yes, actually, this case was a bit overwhelming for me because I haven't dealt with such a case before, and the initial presentation of the case seemed like we are moving towards a degenerative basal ganglia kind of lesion, while the examination moved towards an motor neuron disease kind of picture. So this was my first time dealing with such a case, and that is all. I think my knowledge gap with respect to autoimmune encephalitis is quite big, so I don't have much to share. Anyway, on the treatment front, something I forgot to tell is that, like Dr. Helen mentioned, she was treated with IV methylprednisolone plus pulse therapy, and it was later followed by oral steroids. And he showed significant clinical improvement. And now he was in consideration for long-term immunosuppression, and now he's under follow-up with long-term immunosuppression.
Amazing. Yeah, I mean, hopefully this patient does well. I remember reading from the case that we saw with Dr. Shi, for sure very different from this one, but remember reading that sadly anti-long 5 is not the best responder to immunotherapy, and sometimes leads to progressive neurodegeneration and a sad outcome in death. So yeah, I'm for sure rooting for this patient to have the best outcome possible. But yeah, do you have any final thoughts, Dr. Shi, about or reflections or teaching points that you would like to share with us?
I'm so impressed, Valeria, with your diagnosis of, I mean, like you really came to it with the Exon 5. And I think that what I take away from taking care of patients like this, where there is ambiguity because there are so many findings in the nervous system, is to indeed think about overarching conditions that can affect central and peripheral nervous system. And I think that like thinking about perineoplastic conditions, genetic conditions, toxic metabolic issues is really important. And also that when patients present with subacute progressive neurological symptoms that don't have a clear diagnosis to us, definitely think about autoimmune perineoplastic conditions, even in people who have unremarkable imaging and non-inflammatory spinal fluid. There's just so much that we don't know yet about autoimmune perineoplastic neurological conditions that, I think that it'll be a different conversation 10, 20 years from now, and we'll have a lot more targeted treatments like for IGLAN5. Indeed, the response to immunomodulatory therapies is not strong, but also that many of these conditions are not well characterized yet for us to be able to recognize them from a like pattern recognition perspective. And so I think that, with patients like this, think about those conditions and think about giving them, doing the maximal amount of reasonable workup, such as like sending the extended perineoplastic panel, and then giving them empiric therapy, because there's not a lot to lose, at least from my perspective, when we give people pulse dose steroids and give them IVIG, or sometimes we'll do pulse dose steroids and plasmapheresis if somebody is more severely affected, or at least that's my practice, more severely affected, and then I can always follow that up with IVIG to give them the maximal amount of therapy when I take care of them as a neurohospitalist. And so I think that this case really highlights just the complexity of patients that we take care of, and thinking broadly about their workup, but also about potential treatment. Because for a patient like this, we probably wouldn't get the panel results back, before their discharge. At our hospital, it takes like 2 weeks to get the Mayo perineoplastic autoimmune encephalitis labs back. But to start them on empiric therapy would potentially be helpful, or not would be, like, I think is the right thing to do. And I see that that's what you guys had done as well. Very fascinating case. Thank you for sharing this with us. I think that many people do not get exposure to these specific autoimmune perineoplastic encephalitides, and IGLAN5 being one of them. I have heard about it, I've read about it, I've seen it once, with Valeria's patient, the one that we shared. And so it's really helpful for us to think about these conditions, not necessarily as individual. Well, I mean, knowing about them as individual syndromes is really helpful, but also when there is just a lot going on neurologically, it's subacute, progressive. Keep autoimmune perineoplastic conditions in mind and think about empiric treatment while waiting for results.
Beautiful reflection. So, if anyone wants like more reason to become a neurologist, this is it. We didn't really know about these conditions 20 years ago. So just like a little taste of how exciting the field is. To end the session, I'll pass the mic to Glenn so that he can share some of his teaching points.
Thank you, Valeria. Thank you, Fayed, for sharing this interesting case. So usually my first time hearing about this condition, IG LN05. So definitely read more on the case. Thank you also for the teaching, Valeria and Shi and Sarah, for scribing. So we started off the case talking about the 9 months history of dream enactment. So we approached it as one of the REM sleep disorders. And questions that we wanted to know, at what stage of sleep does it occur? Also ruling out seizures because they can present the same with also aura symptoms as well. Wanting to know more about associated symptoms, any hypnagogic or hypnopumping hallucinations, just to see whether you can put differentials of Lewy body, and also think of Parkinsonism as well. Then in the next aliquot, we talked about autonomic symptoms there, which we alluded to could be Parkinsonism for the rigidity, and put into consideration the hallucinations and the delusions. Lewy body was up there into differentials. We didn't have many to think about the weight loss. So it could be loss of appetite or some paraneoplastic process going on. Then on exam, talk about hypometric saccades, which we that could be due to any hypothalamic or brainstem lesions, and also relates to Parkinsonism as well. Then talk about broken pursuit on exam, which could mean a dysfunction in the brainstem of the brain, especially some supraclavicular areas. So you will also be more susceptible to patients with previous lesions like strokes. And Valeria also considered the possibility of anti-IG LN05 disease, which was the actual diagnosis, because it can present with some cognitive disorders, gait instability, and some sleep disorders. And then we went on to the neuro exam. So we talked about those fasciculations, which could mean ALS, and myoclonic jerks, which could mean which can happen in CJD patients. And we wanted to rule out also metabolic disorders like copper. Any medications that were taken, wanted the EMG at that time. Then also interpreted the MRI, which was normal, which ruled out CJD. So with CJD, we would expect more abnormalities on the MRI. Then didn't really make anything of the EEG with dysrhythmia. Didn't really change the differentials. The ASR was elevated but normal because of the age of the patient. And then the conduction studies suggested a sensory motor neuropathy. So we thought of motor neuron disease, or could be unrelated, maybe a nutrition abnormality. So for the paraneoplastic workup, wanted more specific tests like glycine, GAD65, and wanted to rule out other genetic disorders as well. For the elevated proteins, sort of multiple differentials, rheumatologic, autoimmune, or polyneuropathy. So then we came to the diagnosis of IgLN05 autoimmune disorder. So I really learned a lot from this case. Thank you, Fahad, for presenting. I'll definitely read more on this case.
Thank you, Glenn, and thank you, team, for an amazing session. Yeah, no, I mean, this has completely made my day, if not my week. So yeah, thank you so much, and have a great rest of your day. Bye.